Hello everyone, welcome to our lecture on Chapter 5, Clinical Assessment. Today we will be diving deep into three core components of comprehensive nutrition assessment: the biochemical, the physical, and the functional. These tools are fundamental to our practice as a nutrition professional, allowing us to accurately diagnose and manage the nutritional health of our patients. So let's begin by looking at the overall framework of the nutritional assessment: biochemical, physical, and functional assessment. A thorough nutritional assessment integrates three crucial sources of information: the biochemical data, the physical attributes, and the functional changes. Biochemical data, which includes lab results, physical attributes such as body measurements, and functional changes like loss of strength. It is essential to understand that these are not isolated pieces of data. We must view them in the context of each other. So, looking for the trends and patterns over the time. This integrated approach allows us to observe, analyze, and infer data effectively. The ultimate goal is either detect a new nutritional diagnosis or to confirm that previous nutrition-related issues has been successfully resolved. This process is becoming even more critical as the role of registered dietitian nutritionist continues to evolve within the healthcare system. So the field of dietetics is undergoing significant changes due to healthcare reforms, and this directly impacts our assessment practices. So first, the RDN, registered dietary nutritionists, are increasingly gaining the privilege to write diet order directly within the parameters set by their healthcare organization. The second, there is a major shift in how laboratory laboratory tests themselves provide. They can justify the request with a clinical indicator. And third, the evidence-based medical guidelines are reshaping with tests are ordered and how frequently as we take on these new. It is vital to always ask ourselves a key question before ordering any test: how will these results actually change my nutrition intervention? So this is the key rule, to ask themselves how will these results actually change my nutrition intervention. So let's focus first on the biochemical components in our assessment. The biochemical assessment and the purpose of the biochemical assessment. Biochemical assessment is the cornerstone of the objective nutritional data. So we use these tests or laboratory tests for several key purposes. The first purpose, to diagnose disease, to help diagnose diseases, to provide objective support for our nutrition diagnosis, and to monitor also how effective our nutrition interventions or medical nutrition therapy are, and to evaluate the effectiveness of medication. And importantly, laboratory testing is critical for assessing subclinical nutrient deficiencies. So this means we can identify a problem at the metabolic level long before any physical signs or symptoms of deficiency appear, allowing for early and more effective intervention. So this concept of subclinical state is best illustrated by the nutrient continuum. So what is the nutrient continuum? This graph illustrates how nutrient level in the body exists on a continuum. So look at this graph. So on the far left here, on the far left, you have overt deficiency leading to death, and on the far right also you have toxicity, which can also be fatal and lead to death also. So in between we have a state like suboptimal in the right and suboptimal on the left. So, or can I say abnormal metabolism on the right and suboptimal on the left. So most of these states, particularly the ones that precede overt symptoms, can be assessed in the laboratory. This all allows us to intervene before frank deficiency or toxicity, so deficiency in the left and toxicity in the right, so can be assessed in the laboratory, and this allows us to intervene before frank deficiency or toxicity occurs, which is a key goal of a preventive nutrition. So however, the interpreting these laboratory results requires careful consideration of many factors. So interpreting lab result. It's common mistake to look at the single lab value in isolation. Any single test result must be evaluated in the broader context of the patient. This includes their current medical conditions, finding from physical exam, their medication, lifestyle choices, so these and fasting status. So these conditions which can significantly skew the result. We also need to know if they were fasting at the time of the blood draw. While a single result can be useful for screening, the real clinical value comes from monitoring trends in test result over time. A pattern of a changing value provides a much more objective and reliable measures of a patient's response to nutrition or medical intervention. So to get these results, we rely on various types of biological specimens. So the common specimen type of analysis, the CBC, whole blood counts. The whole blood contains all the blood elements and is used when we need to evaluate the entire content. And serum also is the fluid that remains after the blood has clotted and the cells have been removed. While plasma is similar to serum but is collected with an anticoagulant, so it still contains a clotting factor. We can also analyze specific blood cells like erythrocytes, leukocytes. Beyond the blood also there is a urine analysis and stool analysis or feces analysis. The urine is valuable for assessing excreted metabolites, and feces can be analyzed to check for malabsorption or to assess the composition of the gut microbiota. So while these are most common, there are other less frequently used specimens that have specific also application. The other specimen but low common, like breathe test. Breathe tests are non-invasive tool to evaluate nutrient metabolism, particularly for sugars, and are being used to look at things like fructose malabsorption and bacterial overgrowth. On the other hand, there is hair and nail are easy to collect and can be used to assess the exposure of certain toxic metals, but they have major drawbacks, including lack of standardized procedure and the potential for environmental contamination. Saliva is another non-invasive tools used to evaluate hormone levels, like those from the adrenal glands. And finally, the sweat is specifically the sweat chloride test is a gold standard for diagnosis cystic fibrosis, for example. Now, let's turn to the most common sets of laboratory tests you will encounter: the clinical chemistry panel. The clinical chemistry panel, there is BMP and CMP. BMP, basic metabolic panel, and CMP, comprehensive metabolic panel. So while the current practice is moving toward justifying each individual test, so these the two components, BMP and CMP. The BMP is a group of 8 tests that provides the snapshot of your blood glucose, the electrolyte, the fluid balance, and kidney function. The total of 8 laboratory tests of BMP. Next slide, I will discuss it in details. While CMP, the comprehensive metabolic panel, include the 8 of those in BMP, in addition 6 tests that primarily evaluate the liver functions. So a key point for both these panels is that the patient is typically required to fast for 10 to 8 to 12 hours before the blood draw to ensure accuracy, especially for the glucose measurement. So let's break down the component of the BMP first. These are the 8 laboratory tests: 1, 2, 3, 4, 5, 6, 7, 8. Start from glucose, total calcium, sodium, potassium, chloride, bicarbonate, blood urea nitrogen, and creatinine. So glucose screen for the monitor diabetes. Calcium help evaluate parathyroid hormone functions and calcium metabolism. Sodium and chloride reflect fluid electrolyte balance, while potassium is crucial for monitoring kidney function and blood pH. Bicarbonate or total carbon dioxide assess acid-base balance, and finally blood urea nitrogen and creatinine are our primary markers of assessing kidney function. High blood urea nitrogen relative to creatinine, for instance, can be an indicator of dehydration. The comprehensive metabolic panel includes all of these 8 and adds another layers of information primarily about the liver function. So these the 8: glucose, calcium, sodium, potassium, and here is the reference range of each. You can check it. So the complete blood count, and here is the liver function tests, the panel that includes several liver enzymes, ALP and ALT and AST. Elevated levels of these enzymes can indicate liver injury or disease. And finally, the bilirubin. Bilirubin is measured, which is useful for evaluating liver functions and can also indicate blood disorders or biliary tract blockage. So moving from this chemistry panel, another routine and incredibly valuable test is the CBC complete blood test. The complete blood test provides detailed count of the cells in the blood and give us a description of the red blood cells, when it includes a breakdown of the different type of white blood cells. Also, it's often called hemogram. A key component of nutritional assessment are the red blood cells indices. The red blood cells counts, hemoglobin and hematocrit can all be decreased in nutritional anemias. So the MCV, mean cell volume or mean corpuscular volume, is particularly important because it tells us the average size of red blood cells. So low MCV, known as microcytic, is a classic sign of iron deficiency. So high MCV or macrocytic points us toward folate or vitamin B12 deficiency. The white blood cells help us to assess for infections or inflammation. So high count of white blood cells, that mean there is inflammation or infection. Beyond the blood, stool and urine tests can also provide important clinical clues. So the stool testing can be very revealing. It can tell us about malabsorption, for example, by detecting excessive amount of fat. So we can also use it to identify pathogenic bacteria, especially in case of prolonged diarrhea, or to assess the overall status of gut flora. So the fecal occult blood tests, which screen for hidden blood in the stool, is a routine screening for adults over 50 years. Urine analysis, on the other hand, is a broad screening tool for metabolic and kidney disorders. Using simple dipstick and microscopic examination, it can detect abnormalities like protein, ketones, or glucose in the urine. For example, the presence of glucose, known as glucoseuria, strongly suggests abnormal carbohydrate metabolism and possibly diabetes. On the most critical factor that influence nearly all of our lab results is the patient hydration status. So assessment of hydration status. Assessing hydration is vital because water dysregulation can be associated with many other problems like electrolyte imbalances. So we primarily look for the two conditions. The first, dehydration, which is the excessive loss of water and electrolyte. So the clinical characteristics are rapid weight loss, poor skin turgor, where the skin stays tinted when pinch. The skin stays tinted when pinch, dry mucous membrane, a weak and rapid pulse, and decrease urine output. So the opposite condition, overhydration. Overhydration or edema. Where there is an increase in extracellular fluid, this is characterized by rapid weight gain, visible swelling in the extremities, especially in the peripheral edema, called peripheral edema, and distended neck veins. So several lab values, including serum sodium, blood urea nitrogen, urine specific gravity, can help us to assess hydration, but they must always be interpreted alongside a physical examination. Now let's discuss the physiological state that has profound impact on our biochemical markers. Inflammation. Inflammation is a protective response by the immune system to various stresses like infection, acute illness, trauma, or chronic disease. During an inflammatory response, the body releases signaling molecules called cytokines. These cytokines cause the liver to change its priorities. It stops producing some protein and ramps up production of others. So the protein that increase are called positive acute reactant. The protein that decrease are called negative acute phase reactant. This is a critical concept. During acute inflammation, levels of negative reactant like albumin and prealbumin go down. This drop does not reflect the patient protein status or their recent dietary intake. It reflects the inflammatory process itself. So let us look more closely at which proteins fall into each category. The markers of inflammation in acute phase reactant. This table clearly separates the two types of acute phases reactant. On the left we have the positive, and on the right there is a negative acute phase reactant. So the most clinically relevant of these are C-reactive protein and ferritin. On the right there is in the negative reactant who is synthesis is depressed during inflammation. This group include our traditional visceral protein, albumin, and transferrin, prealbumin also, and retinol binding protein. So understanding this distinction is absolutely essential for correctly interpreting lab data in an ill patient. So let's take a closer look at the negative acute phase reactant, as these are the ones most often misinterpreted in clinical practice. The albumin is the most abundant protein in the plasma. Its main job is obtain colloidal osmotic pressure. It has a long half of about 18 to 21 days, which means its level change slowly during inflammatory stress. Albumin level fall not because of malnutrition, but because the liver stop making it and it shifts into the interstitial space. For this reason, is not reliable marker of protein status in acutely ill patient. So prealbumin, called transferrin, has much shorter half-life of 2 days. Because of this, it was once thought to be a good marker of short-term nutritional changes. However, we know that it is also blunt during inflammatory stress and is not a sensitive measure of how well nutrition support is working. And finally, retinol binding protein has the shortest half-life at just 12 hours, but it behaves exactly the same way. Its levels fall in the presence of inflammation and do not reflect protein status in acutely stressed patient. So this concept of inflammation is also central to understanding certain type of anemias. So anemia is broadly defined as reduction in the number of red blood cells or decrease in hemoglobin concentration below the level of physiological need. It is crucial to remember that anemia is not a disease in itself, but rather a symptom of an underlying condition. So our step in diagnosis anemia is to classify it based on the size of red blood cells, the size MCV, so from the CBC. So microcytic anemia or small red blood cells less than 80 femtoliter is often associated with iron deficiency, while macrocytic anemia more than 100 femtoliter is typically caused by deficiency of either folate or vitamin B12 cyanocobalamin, while normocytic anemia is often associated with the anemia of a chronic and inflammatory disease which doesn't respond to iron supplementation. So let's first look at the specific lab tests we use for iron deficiency. When we suspect iron deficiency, we look at the panel of iron-related tests. Hemoglobin and hematocrit are the part of the CBC, but they are late indicator. They only drop after iron stores are significantly depleted. So serum ferritin is an excellent indicator. So serum ferritin is an excellent indicator of the body's iron storage pool in healthy individual. However, because ferritin is also a positive acute phase reactant, its level falsely elevated during inflammation, making it unreliable in patients with anemia of a chronic and inflammatory disease. So serum iron measures the iron circulating in the blood, but it's a poor index because it fluctuates dramatically throughout the day. Total iron binding capacity measures the capacity of the protein transferrin to bind iron. In iron deficiency, the body produces more transferrin to try to capture more iron, so total iron binding capacity increases. Finally, the transferrin saturation, which is the percentage of transferrin that is saturated with iron, decreases in iron deficiency. So let's shift now to tests used for the macrocytic anemia. The macrocytic anemia are caused by impaired DNA synthesis, which affects the maturation of red blood cells. This impairment is due to deficiency of either folic acid deficiency or vitamin B12 deficiency. So to assess folate status, the most reliable indicator is RBC folate, as it reflects long-term tissue stores rather than recent dietary intake. For vitamin B12, we can measure the serum B12 level directly. However, more sensitive and specific test is methyl malonic acids, or MMA. MMA is an intermediate in metabolic pathway that requires vitamin B12. When B12 is deficient, this pathway is blocked and methyl malonic acid MMA level in the blood and urine increase. Another test, homocysteine. Homocysteine also level will be elevated in both folate and B12 deficiency, as both vitamins are required for its metabolism. So beyond the B vitamins involved in anemia, let's briefly cover the assessment of fat-soluble vitamins. Assessment of fat-soluble vitamins: vitamin A, vitamin D, vitamin E, vitamin K. So fat-soluble vitamin A, D, E, and K are risk for deficiency in any condition involving fat malabsorption. For vitamin A, we measure serum retinol levels. For vitamin D, the standard test of plasma 25-hydroxy vitamin D. There is still some debate, but sufficiency is often defined as the level of vitamin D 30 nanogram per ml or higher. Vitamin E status is estimated by measuring serum alpha tocopherol. Alpha tocopherol deficiency are quite rare except in several malabsorption syndromes. And for vitamin K, we use functional tests called prothrombin time, PT, which measure how long it takes for blood to clot, process that is dependent on vitamin K. So the biochemical markers are also central to assessing risk of chronic disease, particularly the cardiovascular disease. The current guidelines from American College Cardiology, ACC, and American Heart Association, AHA, known as ATB4, identify or emphasize the LDL and HDL cholesterol as the primary markers of assessing cardiovascular risk. A standard lipid panel will give you total cholesterol, HDL high density lipoprotein, and the triglyceride. So the LDL value is often not measured directly, but is instead calculated using the Friedewald equation, which you see here. The LDL equal total cholesterol minus triglyceride over 5 minus HDL. This is equation to calculate low density lipoprotein. And should the triglyceride less than 400 milligram per deciliter to calculate this equation. High sensitive C-reactive protein can be used as a marker of chronic low-grade inflammation that is associated with atherosclerosis. Another major chronic disease where lab values are critical is diabetes. The chronic disease risk for diabetes. The primary tool for diagnosis and monitoring diabetes is HbA1c, hemoglobin A1c. Hemoglobin A1c measures the percentage of hemoglobin that has been glycosylated or bound to glucose. This provides a direct reflection of the average blood glucose level over the preceding 2 to 3 months, because the value is 6.5% or higher is diagnostic for diabetes. It is also a powerful tool for monitoring glycemic control. Another useful test is C-peptide. C-peptide is a fragment that is cleaved from a pro-insulin when it is converted to active insulin in the pancreas, because it's released in 1:1 ratio with insulin. So measuring C-peptide can tell us how much insulin the patient's own body is producing. This is extremely helpful in differentiating type 1 diabetes, where production is absent, from early type 2 diabetes, where production may be high. This concludes the biochemical section. Well, now we want to shift our focus to the second major component of the assessment, the physical assessment, starting with the anthropometry. Physical assessment anthropometry is the science of obtaining physical measurements of an individual and comparing them to established standards. These measurements help us to evaluate growth and development, as well as identify overnutrition or undernutrition. The key to good anthropometry is consistency and accuracy, which require a proper training and the use of calibrated instrument. So the most fundamental measurement we use are height, weight, and various circumference, like head circumference, waist circumference, and hip circumference. So the application and interpretation of these measures differ significantly between children and adults. So let's start with the children and teens. The anthropometry in children and teens, or in adolescent. When assessing growth in children, we use a standardized growth chart. In the United States, it is recommended to use World Health Organization chart for children under 24 months. And the Center of Disease Control and Prevention, the CDC, a chart for the children from 2 years to 18 years. So the measurement techniques depend on the child age. For infants and toddlers who cannot stand, we measure the recumbent length using length board. For older children, we measure standing height with a stadiometer. Weight is a particularly sensitive measure because it reflects more recent nutritional intake. So, on the other hand, head circumference is routinely measured in children up to 3 years of age, but it is primarily used as indicator of non-nutritional issues, as undernutrition must be very severe to affect it. So for children over the age of 2, the most important single indicator, we use the body mass index for age percentile. So the calculation of body mass index, or BMI, is the same for children as it is for adult, but the interpretation is completely different. In children and adolescent, body mass index is not interpreted as single number, but instead plotted on CDC body mass index for age growth to determine the percentile ranking. This percentile tells us how the child's body mass index compares to other children of the same sex and same age. As you can see in the table, the percentile is less than 5th is classified as underweight. A value between 5th to less than 85th percentile is considered a healthy weight, while 85th to 95th percentile classified as overweight, and body mass index above 95th percentile is classified as obese. So now let's turn our attention to interpretation of height and weight. So actual body weight is simply the weight measurement at the time of the exam. Usual body weight is often more useful clinical parameters because it is allow us to assess the unintentional weight loss, though it does rely on the patient's memory. So the percentage of weight loss is a powerful indicator of the severity of illness. You can see the formula here. The Academy of Nutrition and Dietetic and ASPEN have established consensus criteria for what constitutes significant versus severe weight loss over specific time frames. For example, weight loss 5% in 1 month is considered significant, while loss of more than 5% in 1 month considered severe. Of course, the most common way we evaluate adult weight is by calculating the body mass index. And here the category of body mass index. Body mass index calculation, weight over height in meter square. And the value less than 18.5 classified as underweight, from 18.5 to 24.9 normal weight or healthy weight, from 25 to 29.9 classified as overweight, more than 30 or equal 30 classified as obese. So to get more accurate picture beyond body mass index, we need to assess body composition. The body composition assessment, body composition analysis allow us to differentiate between fat mass and lean mass, which is critical for a true assessment of nutritional status. For example, this helps us avoid misclassifying muscular person as overweight. One of the simplest and most useful clinical measures is waist circumference. Yes, waist circumference expresses fat around the abdomen, is independent risk factor for metabolic disease, and waist circumference greater than 102 centimeter in men and 88 centimeter in women is a clinical red flag. More sophisticated methods are also bioelectrical impedance, sends a low voltage electrical current through the body, since lean tissue conduct electricity better fat tissue. It can estimate the body composition. There is also dual energy X-ray absorptiometry. DEXA uses a low dose X-ray to precisely measure fat, bone minerals, and fat-free tissue, and also the air displacement plethysmogram. POD uses air displacement to measure body density, from which body composition can calculate it. In addition to these measurements, hand-on physical exam is critically skills for every dietitian. The nutrition-focused physical examination is a systematic head-to-toe examination of the patient physical appearance to identify signs of malnutrition, nutrient deficiencies, or toxicities. This is focus assessment where we look at a specific body system like the skin, nail, hair, eyes, and mouth, and assess for muscle and subcutaneous fat wasting. There are 4 basic techniques we use. Inspection is simply looking and observing. So palpation involves using touch to feel for things like texture, temperature, and tenderness. Percussion, tapping to assess sounds of body organs. And also auscultation, listening to the body sounds like bowel sounds. So the finding from the nutrition-focused physical examination are then used to help diagnose malnutrition using standardized set criteria. So to assessing malnutrition in adult, there is an Aspen criteria. The Academy Nutrition and Dietetics and Aspen developed a consensus statement outlining 6 key characteristics. There are insufficient energy intake, weight loss, loss of muscles mass, loss of subcutaneous fat, fluid accumulation that could be masking weight loss, and diminished functional status, which is often measured by hand grip strength. For clinical diagnosis of the malnutrition to be made, patient must exhibit minimum of 2 of these 6 characteristics. So these 6 characteristics, so the clinical diagnosis of malnutrition, the patient must exhibit minimum of 2 of these 6. Furthermore, the diagnosis is refined by considering the underlying cause and the presence of inflammation. In this slide, we want to talk about the cause-based malnutrition framework. So malnutrition is categorized based on the presence and degree of inflammation. So starvation-related malnutrition, so no inflammation, for example, anorexia nervosa. Chronic disease-related malnutrition also is if there is mild to moderate inflammation associated with long-term condition, it is called chronic disease-related malnutrition, such as what might be seen in a patient with cancer or organ failure. If there is a marked inflammatory response from recent event, it is called acute disease or injury-related malnutrition, which we would see in patients with severe infections, trauma, or major burns. This framework helps us to better understand the metabolic state of the patient and tailor our interventions accordingly. So to make this framework practical, the guidelines provide specific thresholds of each characteristics. In this table provides specific, measurable thresholds that allow us to differentiate between non-severe malnutrition and severe malnutrition. The exact threshold can vary slightly depending on the context, whether is acute or chronic or starvation-related malnutrition. For example, if we look at the weight loss in the context of acute illness, losing more than 2% of the body weight in 1 week would be classified as severe malnutrition if it is less than non-severe malnutrition. Similarly, having a measured reduction in grip strength is characteristic of severe malnutrition. These criteria allow for a more objective and standardized approach to diagnosis. This brings us to the third and final component to our assessment, the functional measures. Assessing the functional. Assessing patient functional status is emerging and incredibly important part of a comprehensive nutritional assessment. Malnutrition, particularly the loss of muscle mass, directly impacts person's ability to perform activities of daily living. A key tool of this is hand grip dynamometry, which provide an objective measure of muscle function by testing grip strength and endurance. It's a quick, non-invasive test, and we know that decreased grip strength is a significant sign of frailty and is one of the defining characteristics of the severe malnutrition according to the Aspen criteria. Working collaboratively with physical and occupational therapists can provide even deeper insight into patients' functional capacity. Finally, I want to introduce an approach that integrates all these concepts, the functional medicine. The functional medicine is an evolving evidence-based discipline that takes a holistic and systems-oriented approach to health. Instead of just treating symptoms, the focus is on identifying and addressing the root of cause of chronic disease. It's patient-centered, not disease-centered model. The functional nutrition assessment is a key part of this. It integrates our traditional dietetic practice with a newer field like nutritional genomics, a deep focus in restoring gastrointestinal health, managing chronic inflammation, and interpreting a wide range of nutritional biomarkers. The goal to create high personalized assessment and treatment plan that acknowledges unique biochemical and environmental individuality of each person. So that concludes our overview of the clinical assessment. By mastering these biochemical, physical, and functional assessment tools, you will be well equipped to provide effective and evidence-based nutrition care. Thank you and see you next lecture. Goodbye.